All right, everyone. It is 7 p.m. Welcome to another Setting Scoliosis Straight webinar. This webinar is mostly focused on the long-term outcomes of patients who have scoliosis. Um, a lot of us take care of children with scoliosis, and for many families, it could feel like their child was given a diagnosis that really will ruin them for the rest of their life. We want to focus on what is life like after scoliosis, after your child has had their spine corrected. Can you have a full and fulfilling life like everyone else? And we have a dynamic webinar set up to hopefully answer that question. Next slide. My name is Jason Brooks. I'm a pediatric orthopedic surgeon from the Scottish Rite Hospital for Children in Dallas. My co-moderator is Dr. Nicholas Fletcher, who's at the Children's Hospital in Atlanta. Of course, in a surgeon's life, things come up. He is actually trying to get through a spine surgery now. And so as soon as he's done, he'll hopefully join us. We have a dynamic lineup of speakers tonight. Spine surgeons who are world-renowned from all across the country. And then our very own Michelle Marks, who is the executive director of Setting Scoliosis Straight. But we also have Dr. Sigurd Berven from UCSF in San Francisco, Dr. Lawrence Lenke from the New York Presbyterian Spine Hospital in New York, and then Dr. Patrick Cahill from the Children's Hospital of Philadelphia. We also have, which I'm most excited about, no offense to the surgeons, about hearing from actual patients who have had their scoliosis corrected when they were younger. And they're going to be able to give us really their perspective of what life was like, both the good and the bad. So we have Amanda Kopelman, Noel Anderson, and Traci Miele, and we're excited to hear from them also. So, this is a webinar. We want to make this interactive. And so we encourage all of you all to please submit your questions through the question and answer section inside of Zoom. For a selected number of questions, we will actually answer that live. But for the rest of the questions, we will promise to respond to it within a Zoom so that everyone gets their questions answered. So here's our agenda for tonight. Tonight here in Dallas, maybe evening for many of you all. We're going to start with Dr. Berven, who's going to give us a talk about the long-term follow-up for patients who have adolescent idiopathic scoliosis. Dr. Lenke is going to talk to us about some of the long-term issues that may arise for patients who actually maybe don't get their spine fixed and those that do. Dr. Cahill is going to help us to learn a lot more about what happens if you've had your scoliosis corrected and you get pregnant later on in life. How does that affect that experience, as well as you get even older and potentially experience menopause? And then we're going to hear about some of the long-term concerns of patients from their own perspective. And then we're going to end with what childbirth is like after a spinal fusion. But before we get into the webinar, I want to tell you a little bit more about Setting Scoliosis Straight. We are a 501c3 nonprofit organization, and our mission really is to better the discoveries and advance techniques in the treatment of scoliosis in children and adolescents worldwide. We really look to a future where children with scoliosis can have the ability to live a healthy, happy, and productive life like everyone else. So before we get into the webinar, we want to have a message from our sponsor. Briston Foster represents Medtronic, and her company, Medtronic, has been a partner of Setting Scoliosis Straight for a long time. But specifically, they are helping to sponsor this webinar. So we're going to set aside some time to hear from Briston.
Hi, everyone. My name is Briston Foster, and I am part of the Medtronic Pediatric Spine Marketing team. We're really excited to be here with the team tonight and our proud sponsor of the long-term AIS patient outcome study. We really, really value this partnership and are happy to be able to sponsor and further this research. If you haven't seen our company before, meet Medtronic. We are the largest medical device company in the world. Fun fact, I originally met Medtronic in my younger years, and it's a scenario similar to this, as my younger sister is a neurosurgery patient. So the work that we do with Setting Scoliosis Straight is not only near and dear to my heart, but Medtronic as a whole. So here at Medtronic, we focus on engineering breakthrough technologies. We have about 100,000 people worldwide and cover everything from neuroscience to cardiac to stroke and many more. And so our mission as a company is to alleviate pain, restore health, and extend life. And the mission has not changed since it was originally written back in the 60s. And so this not only inspires everything that we do, but drives all the work that we're doing. And advancing this research is truly part of our mission. So we are part of the Cranial and Spinal Technologies division of Medtronic, where we strive to solve complex pathologies. So within our portfolio of the business, these are all of the different disease states that we treat. I really want to introduce another person from our marketing team. This is Josephine. She is part of our scoliosis patient. She's our scoliosis patient mascot, and she's here to help families and navigate your scoliosis journey. And so if you are interested in learning more about Josephine, please scan the QR code where you can see her website and where it'll explain scoliosis, patient stories, as well as our larger Medtronic website where you can learn more about our technologies and implants used in scoliosis surgery. Thank you for the opportunity to talk a little bit more about Medtronic, and we are really looking forward to the webinar.
Awesome. Thank you so much, Briston. Well, without further ado, we're going to start with our first speaker, Dr. Sigurd Berven, who's going to talk to us about the long-term follow-up for adolescent idiopathic scoliosis.
Well, thank you, Jason. Thank you to Medtronic and the Setting Scoliosis Straight Foundation for putting together this webinar. It's my pleasure to contribute. I'm Sigurd Berven. I am an orthopedic surgeon at the University of California, San Francisco. And my practice involves both treating patients, adults and pediatric patients with scoliosis. And I'm going to talk to you about some long-term follow-up studies. And specifically, I want to address the importance of why long-term follow-up is important. It's really important for us to be able to empower informed decision-making, informing both patients as well as surgeons with regard to the developmental disorders of the spine and operative versus non-operative approaches. It can be very challenging to do long-term follow-up studies. Percentage follow-up can be difficult, and there's a real lag in evolution where we're looking at 20-year follow-up. Well, we're looking at surgeries that occurred 20 years ago, and there's been significant evolution and improvement of our surgical techniques and our surgical approaches. What I'm going to show you is that outcomes are characterized by a lot of variability. And this is why it's so important to really characterize or deeply phenotype patients with scoliosis and recognize different types of scoliosis. This gets to the notion of applying principles of precision medicine to adolescent idiopathic scoliosis. And to go through some of the classic literature on this, and what we're going to conclude with is the need for guiding some future evidence. When we think about deformity in the pediatric spine, certainly there's lots of different types of scoliosis, sagittal plane deformities. There's congenital, neuromuscular, syndromic scolioses. Idiopathic is what we're focusing on today. There are also sagittal plane deformities, kyphosis and spondylolisthesis. And in all of these disorders, understanding the natural history, understanding long-term outcomes of operative and non-operative care is really critical. And we've done some work in each of these areas of developmental spinal disorders. The reason it's critical to do long-term studies is that this is, again, what empowers our ability to inform patients and to inform ourselves with regard to what is appropriate. So understanding the natural history, and this is what gets to the notion of characterizing or phenotyping individual patients, recognizing that scoliosis is a broad diagnosis, but we need to treat very discreetly and precisely different forms or different phenotypes. The long-term outcomes, we're interested in both operative and non-operative care. We want to correlate treatment with long-term health status. And I think what's also important to understand is also there are patient preferences, patient values that go into decision-making. Dr. Lenke is going to talk about the transition into adulthood. And again, many of us treat both children and adults. I think it gives an important perspective in terms of when to operate on the adolescent and also when to perhaps to observe into adulthood, in which adolescent developmental conditions may actually progress to symptomatic adult pathology versus which might actually be benign or asymptomatic in the adult. Spondylolisthesis is a good example where early intervention may help in somebody who's got a progressive deformity. And of course, with regard to scoliosis, if it's going to be progressive, then it can be quite disabling in the adult, but there's certainly a good number of cases that do not progress. One of my mentors, John Hall from the Boston Children's Hospital, he used to say that the decision of whether or not to operate is far more important than how we do the surgery. And whether or not to do surgery really just requires a lot of information, again, about long-term follow-up studies. What are the consequences of deformity progression? Again, Dr. Lenke is going to talk a bit about this with regard to the adult, but there are consequences with regard to cardiopulmonary, even mortality, neural impairment, pain, disability, appearance, and self-image. But this is an incredible variety and spectrum that may present. I think this is a classic paper that's worth mentioning, the work of Alf Nachemson in Sweden, where he showed graphs that suggested that there's an increased mortality of patients with scoliosis. But when you actually break it down, many of these patients, most of these patients were not idiopathic cases. This included rickets and polio patients and early onset scoliosis. And when you actually break this down, it turns out that with adolescent scoliosis, we've got normal life expectancy, normal mortality rates, unchanged from unaffected controls. Members of the Harm Study Group wrote this very important paper, then making the distinction between early onset scoliosis and adolescent idiopathic scoliosis. The early onset curves are larger in magnitude, more likely to be kyphotic, had a more distal apex of deformity, had differences in progression patterns. And these characteristics really presented challenges and information with regard to what we might do operatively versus non-operatively for these very different patient populations. Again, I think any long-term study's got to recognize the work of Dr. Danielson as well as Dr. Nachemson, looking at people treated with bracing and with surgery. This was a 22-year follow-up of patients treated with surgery or bracing compared to matched controls. What they showed, interestingly, was that there was very limited progression of deformity in their long-term follow-up. And in general, patients really did quite well with regard to function and pain. And subsequently, we're going to hear about maybe some of this work when we hear about pregnancy and childbirth, where rates of both were similar in the patients treated surgically and non-operatively. Another very important classic study done by Stu Weinstein and a group in Iowa, looking at 117 patients who presented with late onset adolescent idiopathic scoliosis. These are patients who initially presented back in the 1930s and 1940s. Comparing to controls, the patients with untreated scoliosis were very productive, functioned at a very high level. They did have some physical impairment, including back pain, maybe some self-image concerns, but the actual long-term impact 50 years after adolescence was really relatively minor. The curves progressed, importantly. There was certainly significant progression of the curves, but the impact was relatively minor, and patients functioned at a high level. This study out of Zurich, Switzerland, another very good long-term study, 161 patients treated non-operatively with adolescent idiopathic scoliosis, on average 23 years. Some of these patients were followed for as long as 60 years. And they showed there was a clear relationship between larger curves, had more pain, more functional limitations, but very little relationship between curve size or curve location and health-related quality of life, meaning that on average, in general, patients functioned well and had a high health-related quality of life. This is another study done in this case out of Denmark. Benny Dahl was the lead author on this, looking at patients identified with scoliosis back in the 1970s. So the mean follow-up on this was 41 years. So the age of the patients when they were seen was in their mid-50s. And again, there were lower scores in the SRS domain. So when we looked at health-related quality of life, everything except for mental health, so pain and function, were limited in patients with scoliosis. There was more working capacity, but there was a lot of variation. And what I want to point out here is that there's a lot of variation. There's a subset of patients who did have more pain, limited function, limited self-image. Mental health was about the same, but a lot of variation in the outcomes. And the challenge then is to identify, well, who are the patients who do poorly? And we weren't really able to, or this study didn't really show it very well. So bracing versus surgery wasn't predictive of patients having more pain. And surprisingly, the curve apex, so thoracic versus lumbar curves, really didn't predict the long-term function or pain. This study out of Japan, very similar, 256 patients, again, started in the 1970s, 1980s. In this case, we're looking at operative care. They were able to get about 25% of these patients to follow up. On average, it was 30 years after their surgery. And what they showed was that patients who had surgery had lower scores for function and self-image than patients who were in the control. but in this case, no difference in pain, no difference in mental health, no difference in disability. But again, what we recognize here is that these are patients who had their surgeries in the 60s and 70s. Such differences in how we do segmental instrumentation, the kind of curve correction we get, is really not reflective of the evolution of surgery over the past 60 years since that study began. This is an important contemporary study. So this is done by the HARP Study Group Registry, and Dr. Lenke, Dr. Newton were a part of this. 174 patients in Michelle, of course. And the important part being, this is contemporary surgical techniques. So the follow-up's a little bit shorter now, but 174 patients with thoracic structural curves. And in general, patients who treated with surgery did have more pain than controls, but the patients who did worse were the patients who were untreated. So patients with scoliosis who were untreated did worse in each of the domains. So comparing unaffected controls to patients treated with surgery, patients, no difference in function, no difference in mental health, no difference in self-image, slightly more pain in the patients treated with surgery. But the patients treated with surgery in every domain did better than the patients who were treated with deformity non-operatively. So I want to conclude here by saying really the mean is not the message. What we see in some of these studies is an average, but that average really, there is no average patient. And Eric Topol, who's written quite a bit about this, I think says this most clearly. What we need to do is try and apply the principles of precision medicine to scoliosis in deeply phenotype patients, and really trying to get into some aspects with regard to genetics, proteomics, connective tissue factors, that even though these are idiopathic cases, understanding that each case is a discrete phenotype. Social relationships may be even more of a predictor than any of the things we see radiographically. So understanding the phenotype, I think, will give us more discrete ability to analyze what's appropriate for the individual patient. Putting this into mathematical terms, what we're really talking about is, rather than clumping together patients with scoliosis overall, trying to create discrete clusters that are phenotypically precise, and that way we'll be able to really assign the right patient to the right treatment. And I think that's where the future direction of research has got to go. So what I've shown here to start this webinar is that long-term follow-up studies are important. They're important to empower informed decision-making, both for patients and for treating providers. There's a lot of variation in what we see with regard to curve progression and with regard to outcomes. Overall, patients do well compared with unaffected controls. There are reliable differences both in the operative and non-operative groups. The comparative studies of observation, bracing, and surgery are really compromised by significant baseline differences. So we're not comparing the same with the same. And I think future studies really need to define quite discrete variables that are predictive of things like curve progression and that are predictive of long-term outcome. So thanks for giving me the opportunity to lead off this important webinar, and I think we may have some time for some questions.
Thank you, Dr. Berven. That was outstanding. Just to make sure that we catch up with time, we have answered many of the questions in the chat area. So we are going to actually have Dr. Lenke pull his slides up. And if anyone did have a specific question for Dr. Berven, please put it into the question and answer section of Zoom.
Thank you. Appreciate the opportunity to speak tonight. We're going to discuss some issues that adults have, either having had prior spine deformity or scoliosis surgery or not, when they present again in their adult years. My industry disclosures, and probably more important, this disclosure that, again, I've been treating now both pediatric and adult deformity patients for 34 years. So I've got quite a good experience seeing, evaluating, and helping patients, especially adults, decide whether they want to undergo either primary or a revision deformity surgery. And again, we'll obviously use the word deformity, which is inclusive of all scoliosis conditions, just for the context of completeness. So I'm going to focus on kind of 5 prototypical types of adult deformity patients that we see in our practice. Beginning with those, number 1, those who actually have had surgery as a younger child, teenager, and are doing well. And that's actually quite a large number of these patients. Here's a typical patient who actually did surgery on 15 years ago, what's called a selective thoracic fusion, just fixing the thoracic curve and having the unfused lumbar curve kind of stay balanced and unchanged now in 15 years. She was a competitive swimmer, so it was important that we kept her lumbar spine mobile. She swam in college, actually, at Harvard as well. Now is working actually in Wall Street and here in New York City in her profession. But she did very well from the surgery. And again, that's quite typical from most adolescents who are healthy and have these kind of surgeries in their teenage years, do quite well, even up to we have 25 to 30-year follow-up now on these patients. Next group are those who've had surgery as a younger child, teenager, but unfortunately now are having some trouble with their back surgery as an adult. And obviously, as a surgeon, I preferentially will see a fair amount of these patients. That doesn't mean that a lot of these patients have trouble, but obviously those that are having significant trouble will ultimately see a surgeon who does adult deformity surgery for an evaluation. And here's an example, a patient who had juvenile idiopathic scoliosis back in, I think, in the 1990s. This was done by another surgeon, had an anterior and posterior spinal fusion with this hook construct. You see that's something that's a bit outdated currently, but initially did okay from the surgery, but unfortunately, a patient got a posterior wound infection, had the posterior implants removed, and then ended up seeing me at age 24 with the severe what's called crankshaft deformity. So her spine kept growing and twisting in the front, even though it was fused in the back, and ended up with this very severe kyphoscoliosis deformity that required a fairly significant surgery from a posterior approach where we excised two of the vertebrae and then reconnected the spine above and below with this construct here. And she did very well following surgery, both radiographically and clinically, but obviously a substantial deformity and surgery for this 24-year-old to undergo at this point in time. And similarly, a little older patient, a 48-year-old who had a congenital lumbar scoliosis fusion, again, when she was a young teenager, age 12. And this was done actually with fusion in situ without any instrumentation. And she was put in a cast initially in a brace. So this was done again back in the early late 1980s, I believe. So unfortunately, we know that often these spine fusions done without metal, even though they have a solid fusion, they continue to slowly progress. So she got more scoliotic in the frontal plane and a bit more kyphotic or bent in the sagittal plane, and presenting with these x-rays and significant pain at the bottom of her construct, and also some limited pulmonary function because of her thoracic lordosis seen in the side view of the 3D CT scan showed that she had a solid fusion, but again, the fusion was remodeling over time because fusion bone is live bone and reacts under stress, and gradually over time, the fusion kind of mass bends and produces further deformity, and then often degeneration and altered mechanical stresses both above and below the bending fusion mass. So she underwent a complex reconstruction with a vertebral resection to her solid fusion in the middle there, and then what's called posterior osteotomies in the back of the spine to help correct the sagittal lordosis. And following this significant all posterior-based reconstruction, now she has a fusion from T2 to sacrum and ilium. She's well aligned, did very well with this surgery. She's 50 years old now, and the question is, what's life like if when a 50-year-old has this kind of surgery? What can they expect to do following the surgery? And the lady's actually a cardiologist, so one thing she's obviously done very well with her career. And here basically is a video she sent me 2 years post-op, skiing down the slopes of Utah. So these patients can actually often lead quite remarkable lives, even with having their entire thoracic and lumbar spine fused. So wanted to highlight that. So it's not a destiny that patients can't do much. So we actually studied this and just published this in the Spinal Deformity Journal. We've reviewed 26 of our adult deformity patients who were prior skiers, prior to these type of long deformity reconstructions. And the average age was 56. So these are kind of our middle older age adults, and 11 out of 26 actually returned to skiing. This lady was obviously one of them, and it averaged 2.6 years post-op. And most resumed skiing at a slightly less difficulty of slopes and time spent per day, but again, we're able to do this quite dramatic activity. And we've also not only looked at skiing, but we've also published on returning to golf and returning to playing tennis following long construct adult spine deformity surgery. And the bottom line is a lot of the patients can return to these activities at a very high level, again, if they're motivated and understanding of their condition. So it's not a death sentence that you're not going to be able to be very active, in other words, following even significant adult deformity surgery. So the next group that we often see are those who had a deformity discovered in teenage years, did not have surgery, and then now are presenting later in their adult life with either progression or symptoms, often pain, obviously. So this is actually very common for an adult deformity specialist to see these kind of patients. As we know, the younger AIS patients, as Dr. Berven nicely told us about, they do get older with curves that often progress in magnitude. Often get more stiffer and often have more symptoms as they get into the older, what's called adult idiopathic scoliosis, or abbreviated ADIS. So these are patients that just slowly evolve their curves. This 28-year-old patient presented to me with these two large curves, a double major curve pattern with progression over time and increasing pain in her more of her lumbar curve. And we corrected her two curves at age 28 with a T4 to L4 construct with very nice radiographic correction and also nice correction of her large lumbar hump that was also bothering her as well. So surgery done for both progression and pain, and also obviously improved physical appearance. So what's the question is, if you are an older teenager and have curves in the operative range, is it better to wait if surgery timing isn't best for you, in other words, and have surgery as a young adult? Or what's the difference between having surgery as an older teenager or AIS patient versus a young adult or ADIS patient? And we actually reviewed our results and just published this last year, comparing young adults with idiopathic scoliosis who had similar correction rates, a bit greater blood loss and longer operative times, not surprisingly, and a bit more increased perioperative complications, but overall still had safe and successful surgery, very similar to AIS patients as young adults. So those patients were less than age 40, again, having their idiopathic scoliosis surgery, can really expect very similar results versus teenagers, but again, slightly greater blood loss, longer operative times, and a bit more increased periop complications, but none of those complications were serious. Another common patient to see are those in the 50s, 60s, or 70s that, again, have had long-standing curves, often diagnosed as a teenager. And this 69-year-old presented to me with very disabling back pain, leg pain, actually, from stenosis as the spine collapsed on the right side of the lower part of the what's called fractional lumbosacral curve onto her nerve roots. So she was having a lot of leg pain, which was one of her presenting complaints. And she also had a fair amount of overall thoracic and thoracolumbar kyphosis, because she was slightly osteoporotic as well, which is very common. So a lot of issues with this patient. These patients have very disabling conditions. Their trunks start settling into their pelvis. They get rib on pelvis deformities that really are bothersome. So again, treatable with a significant surgery here. This lady had a T2 to sacrum reconstruction as well with osteotomies and what's called interbody fusions at the bottom. And here she's doing her post-op with her radiographic correction into much better alignment, both in the coronal and sagittal planes. We get total body images. You can see the extent of the reconstruction here and her overall appearance in the total body experience perspective. And then her clinical photos here, her trunk alignment seen both from the front and from the side. And we get patient-reported outcome scores, both the Scoliosis Research Society and the Oswestry Disability Index. And the bottom line is SRS scores, higher score is better. Red to green, you see across all the domains are much better. And the Oswestry score, the lower score is best. So she actually had a 0 post-op, which is almost unheard of. That means really no disability at all. It's at age 71, because she was 69 when she had her surgery. So again, quite a significant improvement in this type of patient who underwent a very substantial surgery. So the fourth group is those who never had a spine deformity noted until their adulthood, and now later in life and present with concerns or symptoms. And this is often what's called a degenerative lumbar scoliosis condition. And this patient who presented with this lumbar curve and a bit of sagittal malalignment as well. But one of the main symptoms is that he had severe spinal stenosis. So he had narrowing of his spinal canal, producing a neurogenic claudication or trouble walking, and specific radiculopathy or leg pain in both of his legs because of his significant stenosis that was primarily at L3 and L4. You see the tight sac there versus L5, the big white sac at L5S1, which is much more normal. So this patient had surgery not only for control of his scoliosis, but also for decompression of his spinal canal to relieve his stenosis symptoms, and with realignment of both the coronal and sagittal plane being performed as well, with a very nice radiographic and clinical result from the surgery. In the last group, those who've had lumbar degenerative or deformity surgeries in adult, they now have an iatrogenic deformity problem. Unfortunately, not all degenerative or deformity fusion surgeries go well in adulthood, and sometimes those need to be redone. This 58-year-old had a single level L4-5 unilateral minimally invasive TLIF, decompression and interbody fusion approach. I think 4 or 5 years prior to presenting to me, and she's falling off, leaning to the left, leaning forward, and had a lot of arthritis both above and below her prior L4-5 fusion, which was solid. But it was solid and not a very good anatomic alignment, especially from the side. She had a flat back posture because of this. She also had very severe stenosis at L3-4 versus her L4-5 level was nicely decompressed in the large white sac there. So she had to undergo a revision surgery for her initial minimally invasive fusion with a large osteotomy at the bottom of her spine at the L4 level to realign her spine in both the coronal and sagittal planes to get her standing upright. Here she is 5 years post-op. Her global films show excellent both coronal and sagittal alignment. And again, her pre and post-op SRS scores showed marked improvement in her quality of life following this surgery. So in conclusion, on average, adult spine deformity surgery is a bit more complex with higher operative times and complication rates on average than pediatric deformity surgery. Overall, and logically, younger adults tend to do a little bit better than older adults for most surgical conditions. There's still much research that is needed to be done on deciding on the best indications and techniques to provide more consistent, optimal short and long-term results with lower complication rates in the adult spine deformity patient. But however, as I've also shown you, many adult deformity patients do exceedingly well postoperative and lead a very normal life in gratitude they underwent their surgery. So the key is picking the right patient at the right time to do the right surgery. And often these patients will do quite well following their adult deformity surgery. So answer any questions. I'll stop sharing at this point. I think we're running a little bit behind still.
Thank you, Dr. Lenke. That was outstanding. We have time for one question that was asked, and it's related to the adjacent segment degeneration. A lot of the questions patients have asked is, what are the odds of the vertebra that are not fused potentially degenerating and requiring additional surgery in the future? If you could maybe walk patients through quickly how you tell them about the risks of adjacent segment degeneration if their child has had their spine fused at a young age.
Sure. So that's always going to be a potential concern, an issue. Again, either almost always above the fusion, because we're rarely ever starting at the skull, right, with our fusion. And obviously below a fusion, as long as the fusion is not starting at the sacrum and pelvis, as many of the adults that I showed obviously had to have that done because they've had already pre-existing degeneration down there. The risks are really variable. It will never be zero. And there's many factors that lead to an increased risk, including the patient diagnosis, patients who have connective tissue disorders or other syndromes are often at higher risk than idiopathic patients. Certainly, one of the keys is a very well-done surgery. Picking the correct fusion levels for the upper and lower instrumented vertebrae is very critical to decreasing the adjacent segment risk both above and below. Getting the right amount of correction during surgery, not over or under correcting, but just the right amount of correction is also part of that. But again, overall, there's also time. Unfortunately, time is a bit of our enemy. With time, the spine does have increased stress at the levels directly above and or below a fusion. So with time, often those segments do degenerate. Then they don't always become symptomatic, but they will almost always degenerate over the decades, past deformity surgery. So again, something we always discuss with all our patients, especially our young and middle-aged and older adults, because it's much more common to have that occur more quicker following surgery in the adult world. But it's something that we're still having to deal with and still looking for the best ways to minimize the occurrence of these adjacent segment problems.
Awesome. Thank you, Dr. Lenke. We're going to now move on in order to hopefully catch up. We're going to have Dr. Patrick Cahill tell us about pregnancy and menopause and how that affects patients with scoliosis. And he's going to catch us up. We're
Yes.
going to be on time right after his presentation.
Yeah. So yeah, thanks a lot, Dr. Brooks. So obviously the exciting part of this webinar is that there's some women that have gone through the process of having scoliosis surgery and are now living their lives. So we can talk about data and science all you want, but actually hearing from those people that have lived it is going to be much more valuable for what we're trying to get at. There was a question though from one of the audience members about life and pregnancy after a fusion for AIS. So I'm going to try to do a rapid fire, quick one hitters on answering some of the key questions that a lot of my patients ask me when they're considering surgery as teenagers. And what is it going to mean for their ability to become pregnant, their ability to have a full-term pregnancy, their ability to have, what is the scoliosis surgery going to do in terms of the labor and delivery? Are they going to have a C-section? Will they be able to get some of the anesthetic medications like spinals or epidurals? And so I'm going to try to hit all those key questions. So the first one is my back going to be more painful during pregnancy because I have scoliosis, or if you've had a scoliosis fusion because you've had a scoliosis fusion, is that going to make the pain even worse? And the answer is we don't know. It's hard to say. There's some conflicting studies on this. The one thing that we know that's clear from the asking pretty much any woman that's ever been pregnant is that pregnancy is a pain-inducing event in your back, and whether or not that pain is somehow magnified because you have scoliosis or because you've had a fusion is not totally clear. But I think we're going to hear from some of our panelists some of the strategies that they may have had for minimizing that pain or trying to minimize the severity and frequency of episodes of pain during the pregnancy. And I think a lot of it goes along the same lines of good back health long-term, which is keeping your core muscles strong, trying to keep yourself lean and active, and trying to avoid getting too tight in the hamstrings in particular. So some of the other questions, can I have a full pregnancy? The data shows very clearly that you can go to full term with your pregnancy. You don't have to go early. And will you be more likely to have a C-section? Well, let's kind of talk about some of these questions, because these are questions that the harm study group is trying to answer. So here's some of the data. So one of the first studies came out of Scandinavia, where everybody stays in the same place and they can follow these patients long term. They did rate their back pain not higher in Scandinavia, and they had the same number of children, but maybe at a little bit later in life. So some of the questions we're trying to answer with the harm study group is, what is the impact really on pregnancy, and particular childbirth? So spinals and epidurals involve a spinal tap, which is placing a needle between the vertebrae and into the spinal fluid. But if you've had a spine fusion, that fusion will block the ability to get the needle in at that level. The good news is that the vast majority of women that have had surgery for scoliosis as a teenager or a child have not had a fusion all the way down to their pelvis, as Dr. Lenke was indicating, but do have some spine that hasn't been touched with previous surgery below where they've had their surgery that can be accessed for these types of anesthetic events. So patients did not seem to meet with their anesthesiologist very routinely before their pregnancy. And this is one of the things we've got a little cheat sheet that we give our patients, and I'm going to go over that at the end of this talk, about how to kind of plan your pregnancy and talk to your obstetrician early in the pregnancy to be your own advocate. So some of the things we found is that pregnant women that have had a scoliosis fusion surgery seem to be getting spinals and epidurals at a rate much lower than the general population. And we think that's largely because of our poor job that we've done at educating our colleagues in anesthesia and obstetrical anesthesia in particular. But also we want to arm you to be your own advocates in these discussions with your obstetricians. The other questions are, does having had a scoliosis surgery put my child at risk for having some sort of complication or malformation or injury during the delivery? And the answer seems to be pretty clearly no. So here's our checklist that I think it's important for a woman to have when they're contemplating pregnancy or early in their pregnancy and discussing with their obstetrician their plans, so that they can kind of get the care that they deserve. So keep a copy of your x-rays. I think this is a picture tells 1,000 words. Show your obstetrical anesthesiologist where your fusion ends, and they will be able to clearly see that you have room to place a spinal or an epidural. Also have them examine your scar so that they can kind of make a plan where they can try to put the spinals and the epidurals. You should know yourself what your lowest level of your spine fusion is. Most of your doctors will tell you, oh, you had a spine fusion from something like thoracic 4 through lumbar 1, something like that. You have to know your exact levels so that you can have that conversation with your obstetrician. And then make sure your obstetrical team is comfortable caring for mothers that have had scoliosis fusions. And if they're not, please reach back out to your original surgeon, so that they can guide you to somebody who does have that expertise. So in my region, I work very closely with the maternal fetal medicine doctors at the University of Pennsylvania to take care of my former patients. And then talk about this early and be your own advocate. And then ask them if they're familiar with this situation. Ask them if they think that this is an immediate condition that precludes the ability to have a spinal or an epidural, and see how comfortable your obstetrician is with your thoughts and needs. And then your surgeon is willing to talk to your obstetrician if they have questions for us. And even if you're decades out from care, your surgeon is also willing to hear from you and help you with questions that you may have about your spine as you go into these pregnancies. And last but not least, we love baby pictures. So after all is said and done, we love hearing how your life is unfolding and how beautiful your babies are. And then the last thing I was asked to cover is, does having scoliosis and menopause seem to be another trigger point where scoliosis may become more painful or worsened? And I could not find great data, and I would love to hear from any patients that are willing to be brave enough to share their stories. We know that this is a time in life where there are hormonal changes, there are changes in muscle density, and decreases in bone density, all of which may have some impact on whether or not you're going to have pain in your back. And the last question I skipped over a little bit: will my scoliosis get worse during pregnancy? The answer is maybe slightly, but it won't kickstart scoliosis progression that will continue after the pregnancy. And I will end it right there, Jason. Hopefully I got us some time back.
Thank you, Dr. Cahill. That was outstanding. A question that many people ask is, oh, I was fused to L2 versus L3 versus L4. Yeah. Does that significantly affect whether a patient who had their spine fused to any one of those levels as a teenager will be able to get an epidural if they get pregnant later on in life? How much does a lower fusion level affect those things?
That's a great question, Jason. And I don't know the answer definitively, but it seems to me that even if your fusion was down to L4, there's still two interlaminar spaces where a skilled obstetrician should be able to get a spinal or an epidural needle into the spinal canal and into the spinal, the CSF space if they needed to.
Outstanding. Okay. Well, thank you, Dr. Cahill. We are going to move on to our next section here. And we are going to go ahead and introduce Michelle Marks as well as Amanda Kopelman, presenting the long-term concerns of patients, as well as conducting patient research.
Hi, everyone. I hope you can see my screen. My name is Amanda Kopelman, and I'll be talking about some long-term patient perspectives as a patient and now researcher. So when I was 8 years old, this little picture of me when I was 8, I was diagnosed with scoliosis, and I wore a brace for what seemed like forever. And finally, at age 13, we made the decision to have spinal fusion. And prior to my surgery, I was an active dancer, and I did some figure skating as well. So I led a very active life. I had to wear my brace for 22 to 23 hours a day. So I was pretty compliant, and I think that definitely helped in the process. And so this is me during my surgery. Dr. Schuffelbarger was my surgeon, who unfortunately recently passed away. And not only was he my surgeon, he is such a longtime mentor of mine as someone who is planning to go into medicine right now. So this is my surgery. This is the x-ray from day before my surgery. I was fused from T2 to L1, and this is the side profile view, which I think he did a pretty good job on. And so currently, from all of that experience and, living through having scoliosis and being with doctors and surgeons for so long, I really became interested in the idea of initially medical device design and then wanting to be a doctor eventually. So I just graduated last year from BU and I studied biomedical engineering. So during that time, I studied a lot of medical device design, and I was able to work at Boston Children's Hospital doing a lot of retroactive patient studies on the surgical robots and navigation systems that are really exciting and innovative in the spine division right now. And I'm currently at the Icahn School of Medicine at Mount Sinai in New York City, doing actually clinical and animal mouse spine deformity research. So our lab is working on one of the first studies in our lab to understand how scoliosis progresses and impacts muscle tissue, which is something that I'm very passionate about as someone trying to understand how pain works in the scoliosis process. And like I said, I'm working on applying to medical school right now, which is very exciting. And something I'm very passionate about and have grown to love is really working with patients. So last year, Michelle Marks, I reached out to her and I said, I think we need to work on something that involves our patients to understand what they're looking for in research and what they really want to see. So we launched the Patient Research Advisory Committee, which is something I'm very proud of and something new to the Harm Study Group and Setting Scoliosis Straight. And our goal is to really incorporate these patient and family perspectives into our research priorities. So as a researcher myself, I read daily all of these screw placement studies, lots of animal studies, lots of things that patients wouldn't typically understand or want to understand. And so our goal is to understand and hear from patients what their concerns are and to provide some feedback on ongoing and proposed research projects to help them feel confident and comfortable about the direction that our research is going in. So we put together a really exciting team of myself, Christian, who is a PhD candidate at Drexel, and Emma, who is a biochemistry student at UC San Diego, who's applying to medical school as well. We all had AIS, and we are all in research. So we're all very passionate about this, and we're looking to obviously grow our team of students who are really passionate about this. And our mission is obviously to close this gap between the researchers, physicians, and patients to help understand and explain to them in layman's terms what's really happening to them and to understand that. So in June 2025, we sent out this large survey to our SSSF family group, so all of the families who are enrolled in this study. And we had 98 respondents, and we gathered some basic demographic data with a lot of ranking questions about pain and things like this. And we had two really important open-ended questions that we wanted to know the challenges of the scoliosis management and treatment and what questions or concern they have in research specifically. So we learned a lot about some patient challenges, about bracing discomfort, sleep issues, lots of concerns about scar, physical body, lots of questions about pregnancy, which I think was discussed really well today and is something that I'm really passionate about as well. And I think that a lot of patients share lots of similar concerns, which is something that was really exciting to us to read about. So from this study, we were able to categorize 4 different groups of research priorities that Michelle and I are really excited to move forward with. We want to improve some life outcomes that are listed here, reduce some long-term burden like hardware failure, and educate our patients on this. Work on improving daily life, whether that be Pilates, physical activity, what that looks like, growing up, if you've had surgery when you're 13, like myself, and are just aging, what does that process look like? And then we also want to empower our patients to make informed choices and have access to care. So these are some things that we're really excited about, and I'm very excited to turn it over to Michelle to talk about our research.
Thank you so much, Amanda. It's so wonderful to have you and all of our scoliosis ambassadors involved with us. Can you guys see my slides? Yep, great. Okay. So as you've heard from Dr. Lenke and Dr. Berven, there have been studies on long-term follow-up, but there is an existing knowledge gap. And that is that there really isn't a comprehensive comparison of modern instrumentation with AIS fusion patients to non-operative patients that are in that operative greater than 40-degree range. It just currently doesn't exist. And so the benefit of the harm study group's 3 decades of dedicating to scoliosis research. There are research sites now that have been enrolling patients in our prospective study since 1995 and doing continual longitudinal follow-up on those patients. And now many of them are due for their 20-year follow-up. So 4 sites of the HARM study group are locating and seeing these patients in San Diego, Philadelphia, St. Louis, and New York. And then our leadership has engaged 6 international sites to collect data from non-operative patients from Japan, Singapore, Montreal, and then the US, Rochester, and Pittsburgh. So the data being captured at these long-term visits encompass radiographic outcomes, which we typically do in the prospective study as well, looking at correction, stabilization, or progression, and spinal alignment, and evaluating the instruments, the constructs themselves. And clinically, we're focusing on measuring trunk flexibility, adverse events, or comparisons, and the pain levels in both of these cohorts. In addition, we've compiled multiple patient-reported outcome tools that have been in previous studies to allow comparisons between cohorts, which will provide information what we feel could be the most important, which is patients' health-related quality of life. And as you heard Dr. Cahill report on previous pregnancy data, we're also going to be continuing the pregnancy questionnaire that he launched many years ago to give even more valuable data on pregnancy in the AIS, both operative and non-operative patients. The current demographics of our op and non-op patients are closely matched thus far in age and gender. The non-op patient data collection is slightly ahead of the operative patients, but our goal is really to have about 100 patients in each group. And then we're also going to have a third comparative control cohort. Healthy, no scoliosis individuals are going to be recruited with these inclusion criteria that they live in the same city, they're around the same age, and that they're willing to do these questionnaires. So if you have any friends or family members that are within the age of 32 to 44 speak English and live in one of those cities, please have them reach out to Daniel Ludwig. He's our HSG study coordinator and helping us run this effort. And we're really extremely grateful to Medtronic for the research support to help us answer this question of who is doing better in the long term. You know, as a parent, I understand that every decision you make for your child comes with the wish for a crystal ball, a way to see the long-term impact before you choose how to move forward. You know, my hope is the data from this study is going to provide patients and families with the evidence-based information they need to feel confident, comfortable, and optimistic with their scoliosis treatment decision. Thanks so much.
Thank you so much, Michelle. Thank you so much, Amanda, for sharing how research can really help us to get to the answers that we really need in this challenging diagnosis. We're going to actually leave this time open for any potential questions about some of the research that's being performed. Specifically, there was one question that was asked quite a bit earlier about how you feel, Michelle, potentially AI might help us to understand or answer some of these questions related to the long-term outcomes of patients.
Well, I think we're having such a rich, large data set of patients really using machine learning to help us understand good outcomes and bad outcomes and what patient characteristics or what surgeon or surgery approach characteristics all related to those outcomes is going to be assisted with the use of machine learning and AI. It's still going to take a human component, but it's exciting to see what's going to happen.
And I had a question for Amanda. Did your experience of having scoliosis, does it allow you to connect with patients who you are talking to about your research project? Because sometimes it is hard to convince patients to take part in these studies. How do you use your prior experience of having had scoliosis and having it corrected to kind of connect with your patients?
Absolutely. I also think that was one of the main reasons why we wanted the group and the research committee to be full of students who had undergone this process. So I think there is sort of an empathy component to it where people who are looking for help or looking for resources or want to read something to educate themselves might feel more comfortable, like, oh, these researchers went through this and they're dedicating a portion of their life to helping others improve their life or their livelihood. And I think for me as a patient, if I were to go back and I had this group before me, I would feel a little more comfortable trusting them. I'm not saying I don't trust doctors. I love all of you guys, but I think there is a connection aspect that is really important in medicine.
Outstanding. Well, Thank you for all that you're doing. We're going to move on to Noel Anderson, who's going to share her experience of life after scoliosis surgery.
Yes. Hello, everyone. My name is Noel Anderson. I have been volunteering with the Setting Scoliosis Straight Foundation since 2021. And today I'll be focusing mostly on what my life is like 11 years post-operation. But quickly, I do want to just talk a little bit about my background. I was diagnosed with scoliosis in the 5th grade, and then I ended up doing bracing. Wasn't the best bracing patient, and ultimately had spinal fusion surgery where they placed 2 rods and 19 screws in my spine. I had my surgery at Shriners Children's Hospital in Spokane, Washington. So the next part of my journey is I turned my pain into a purpose, and Setting Scoliosis Straight helped me with that. I found many ways to advocate not only for myself, but for other patients and connect with them and empower them through education, research, and advocacy. And that's why I love the Setting Scoliosis Straight Foundation. But really what I wanted to talk mostly about is what I'm doing now. So my journey with recovery was not linear by any means. When I was in high school, a couple years after my surgery, I kept playing soccer. I was a goalie, which is a very physical position where you're slide tackling people, throwing yourself on the ground. And I was able to do that with metal in my back, but I was very hesitant and ended up just not wanting to play soccer anymore. And that's when I found pageants where I was able to advocate for scoliosis awareness. But I'd come home from school and my back was just killing me from my backpack. I'd cry from the pain. And this was after the surgery. And I found through the years that when I'm being too sedentary, when I'm sitting too much, when I'm not being active, is when I have the most pain. So when I got into college, I learned more about movement and exercise and massage therapy. So that's the final component here is I think everybody should take care of themselves and exercise and eat well and recover and, stretch and take care of their bodies. But scoliosis is really what keeps me disciplined with having that metal in my back. And so now my pain is way better than it was when I was in high school. And I'm 25 years old now. So as I'm getting older, my pain's actually getting better because of the discipline that I have with taking care of my body. So strength training and weightlifting has really improved not only my appearance, but my confidence as well as my pain levels. And then I get massage every other week. And I am, very lucky to have insurance that helps cover that. But I highly recommend that to anybody, especially those with scoliosis, though, that you can still go out and do many things. You can still lift heavy weights and go skiing. I love that there was an example of skiing. I actually went skiing for the first time since I was 13. And I had my surgery when I was 14. And I remember the surgeon telling me that skiing is kind of a dangerous thing to do. So here I am 11 years post-operation. And I said, you know what, I'm going to go skiing. And I did it. And I only fell a couple times and my hip is bruised, but my back is fine. So just an example that you can continue to have a great life. And it's just important to take care of yourself and advocate for yourself. Thank you.
That's absolutely outstanding. Thank you so much for sharing your experience. And hopefully there are patients that are on this who are teenagers now who can hopefully project out and see what their life might be like in the future. Can you talk a little bit about what sort of physical or sporting activities you were able to get into? I guess when you were cleared by your surgeon, were you told that you couldn't participate in any things like gymnastics or any sort of contact sports? How did you deal with sports as a teenager?
Yeah, so I touched on this a little bit, but I played soccer. That was my main sport as a teenager. And after my surgery, 6 months after, I was able to run. So I started, trying to jog, but I could only walk for 6 months. And then it was 9 months after my surgery that they cleared me to play soccer again. And so, as I mentioned, I was slide tackling people and, diving on the ground and still was able to do that. But honestly, yeah, I got back into it. My surgeons were very encouraging in that process and didn't really tell me I couldn't do anything. It was more just, they told me it was going to be a little bit different, which is true. Like whenever I do a yoga class, I cannot do all the cool bendy, twisty things that everybody else is doing. But I can still, find other ways to exercise and strengthen my body.
Outstanding. We have one live question for you, Noel. They want to know, did you have more pain before or after surgery?
I would say I had more after, but I also think when I was 13 or 14, I feel like I wasn't very aware of my body as much as I am now, because I feel like I've always been very in tune with my body after my surgery. But I don't think that's necessarily a bad thing because it does help me advocate for myself and also know how to take care of myself. And that's a big reason why I stay active and make sure I get massage and just take care of my body. But, I would say overall a little bit worse after, but as mentioned, really movement is medicine, and that's what improved my outcome.
Great. Thank you so much. Well, without further ado, we're going to go to our last patient presentation. Traci Miele is going to talk about what life is like, particularly when it comes to childbirth after a spinal fusion.
Hey, I'm Traci. Thank you for having me tonight and letting me share my story. I will be discussing childbirth after fusion, and I will not be handling my slides as I cannot do two things at once. So, next slide. I was diagnosed with scoliosis at 11, and I believe my curve was about 41, 42 degrees at that age. This was 1991. I was braced for 2 years in a Boston brace, and by 13 years old in 1993, my curve had progressed to 81 degrees, and I had Harrington rod surgery. Aside from a few minor limitations, aches and pains, just very few, I've led a normal teenage life. I had no issues really. Next slide. So I started my family at 26 years old, just 13 years after my spinal fusion. And I had a great pregnancy. It was my first pregnancy. It was great. I gained 50 pounds. So I was a little worried about carrying 50 pounds with a fused spine. And it was great. I had no problems. What I did not do was prepare for every scenario. I did not have x-rays to present to my doctor. She did look at my back. We did kind of discuss. I wasn't even aware at that time what my fusion was. She looked at my spine. She did talk to anesthesiologists. They were very confident about an epidural when the time came. They were pretty sure they could get one in. It was time, and that epidural did not happen. I lost count of epidural kits. I was not prepared for a natural childbirth. So if I could give any advice to you ladies ready to start your family after a fusion, it would be come prepared. It would be to show your x-rays, be your own advocate, as Dr. Cahill said. I would recommend taking all the breathing classes you can because you really don't know what your outcome is going to be. That's going to be your saving grace, is to be prepared for both scenarios, medicated and unmedicated. I was totally prepared for number 2 and number 3 after that. But coming home with a baby, coming home is a different learning curve as well. I found muscles that I never knew existed. You got to think about, you're holding a baby, you're feeding a baby, you're leaning, you're picking up this baby, you're using muscles, and your muscles, they're constantly contracted for longer periods of time, longer than you're used to. And we're already pretty asymmetrical. If you're on this webinar, you are asymmetrical. Then you load with 8 pounds, 9 pounds, and you're asymmetrically loaded. It's something that you've got to prepare for. I did not prepare for that. I didn't have anyone who could express that to me. I didn't know anyone who was fused who had experienced childbirth. After the first pregnancy, I hired a trainer I found a fabulous physical therapist. I got stronger. I actually dove into training myself and became a certified personal trainer. I loved it. I was so prepared for number 2 and number 3. I was stronger. I knew my body. I knew my limitations. I knew what I could do. I knew what to expect. I did. I Goodness, I just cannot stress enough to find a physical therapist. I found a female physical therapist that focused on pelvic issues. That's huge. I did not realize until after the second pregnancy how important that is. And I still work with her today, and it's an amazing experience. And at 46 years old, I still I still really feel like that's something that I will do for the rest of my life, and would tell everyone, if I could give you any advice, strength train, learn your body, find a physical therapist, and really advocate for yourself. Come prepared to all of your appointments. Know where your fusion is. I was not prepared in that department, and you will be glad you did. And that's yeah.
Thank you so much, Traci, for sharing your story. That was outstanding. I cannot admit I've never gone through childbirth myself, but something that I did kind of realize as my wife went to the hospital for the 3 different times for our kids was that, you know, we would see the same OBGYN, but when we got to the hospital, the person that would actually be administering the epidural, it was 100% random. It was whoever was on call that day. And so even if you came with your x-rays, like how does a pregnant woman advocate for herself when she might be meeting this, CRNA or this anesthesiologist for the very first time, and they're just on for that shift. So they have, they're planning to do a straightforward epidural, and they're not expecting to, see this person that has a prior fusion. How do you work around some of those details?
Well, that is exactly what happened. I think we went through many epidural kits the first time. The second time I said, one time, you get one shot. And I wasn't going to do it again. I gave him one shot and it didn't work. I was just prepared the second round. So I would say everyone prepare for your first round, know that there is a possibility this might not happen. And actually, the first time was so stressful because we were so focused on this epidural that it really almost ruined the experience for me. It's a very life-changing experience. You want to enjoy it and you want to embrace it. And it was that epidural really messed me up. So I wish I would have known my fusion. I would say that. But just be prepared. Be prepared that you might not have one. It's a possibility.
Excellent. So we have some more questions coming in. Did you utilize a partner or a doula in any way with any of the conversations with your children as you kind of went back to for more kind of pregnancy events? Like, do you think there's any role for a doula to make that conversation more streamlined or the process more balanced?
I did not use one myself, but this was back in 2006, 2009. Natural childbirth had not really come back into. It wasn't as back. It came back into popularity after that. By my third one, breathing techniques and all that kind of stuff. That was more mainstream. I would think that using a doula would be kind of cool to do. I didn't have that opportunity. I don't believe my hospital really allowed it where I am down here. But I did kind of research a little bit about it. I did take all of the breathing classes. That's the extent that I knew to do at that point. Now I would say probably. I think that would actually be a really good thing to look into.
Outstanding. And then we did have one question that was asked, and I'm going to put this towards either Dr. Cahill or Dr. Lenke. There are a lot of questions that we saw from patients where they might have a curve that stopped at around 30, maybe 35 degrees as a teenager, and it's just been followed as they've gotten older and older. Is there any way that these now adult patients who have a 30 to 40 degree curve that never got surgery, is there anything they could do to stop the progression of those curves? Like, how much should they be worried that these curves are going to get bigger and eventually require surgery?
I can take that. So, our natural history studies show that the size of the curve, the Cobb measurement does have a predictive feature for that, as you know, Jason. So, on average, when someone is done growing and their curve is less than 40 to 45 degrees, there's a good chance that the curve may not progress. So it may kind of stay in the 30 to 40 degree range throughout adult life. Whereas curves that are well over 50 degrees, 50, 67 degrees, almost all of those curves slowly progress, typically 1 or 2 degrees per year. So the time mark is around 40 to 55 degrees of curvature of Cobb measurement curve, at least for thoracic curves. Lumbar curves a little bit different because they can progress a bit more in the older adult life with increased arthritis and degeneration. But for thoracic curves, it typically is based on the Cobb measurement when you're done growing.
Excellent. It's maybe a bit more of a controversial question, but it's been asked multiple times. In your experience treating adults, does Schroth physical therapy have a role?
Absolutely. Schroth is a great therapeutic method for optimizing kind of body alignment, muscle balance and tension, relieving symptoms of scoliosis. So it definitely has a major therapeutic role. Unfortunately, for adults, especially again for curves that are substantial over 40, 50, 60 degrees, it really won't halt progression of curves if they are progressive, but can certainly help patients control their symptoms and optimize their kind of body mechanics and muscle strength and flexibility. So it's definitely plays a big role in the I think both pediatric and especially the adult deformity world.
Outstanding. Well, we could literally do this webinar for probably the next 2 hours. We have so many questions, but we're already 15 minutes over. And so thank you for all of our panelists who shared their stories and shared their literature. For everyone, I want to make sure that you take a look at our Setting Scoliosis Straight handbook. This handbook pretty much has everything that you need to know about the scoliosis journey from the time that you're diagnosed all the way up to life after surgery. There are outstanding stories, great pictures, and really a great data that you can kind of really read as you progress through the scoliosis journey. And the better part is that this thing is completely free. And so you all can see this QR code here. You can scan the QR code right there with your cell phone. You can also get this from the Setting Scoliosis Straight website. Next slide. We also have an outstanding YouTube channel. So many of these webinars are also hosted on our YouTube channel. We have lots of educational videos. We have videos that focus on many of the publications that have been produced by the Harm Study Group. We have lots of patient stories and interviews, as well as we have a frequently asked question section also with lots of videos. So please check out our YouTube channel, which again, you can reach from the QR code there. We encourage you to visit our website. As I said, some of the things that you find on our YouTube channel, you can also find right on the Setting Scoliosis webpage. Really, and we have a podcast, we have patient stories, and again, lots of great content for you all who may have wanted your question answered, but weren't able to get it here on this live session. Next slide. And then finally, if you all appreciated what you heard tonight, again, we really appreciate our sponsor, Medtronic, for putting this on, but it takes a lot of resources to put on webinars like this. If you all found any value in this, we really would love for you to donate even at least $10 to the Setting Scoliosis Straight Foundation so that we can produce more content like this, again, related to scoliosis, and hopefully showing as many kids as possible that you can live a full and fulfilling life, even though you have scoliosis. Next slide. And then finally, we have lots of future webinars. So please take your cell phone out and kind of take a screenshot of this. We're going to have a webinar in April where you get to ask the expert pretty much any question that you want. We have another webinar titled in June, You Are Not Alone, where hopefully you kind of get a chance to hear from others who have gone through this scoliosis journey. And then the age-old fusion versus tether discussion. We're going to talk about that in August, so please stay tuned for that. Next slide. And finally, we want to thank all of our speakers as well as our patients for sharing your stories, for sharing your time. For all of you all that were registered to this webinar, you all will receive a survey. I know everyone hates filling out post-meeting surveys, but this is really helpful for us to know what sort of topics to cover in the future, so we can hopefully provide the best content possible. And of course, our contact information is there if you need to reach us. Thank you again to Medtronic for sponsoring this, and we hope to see you at our next webinar.